was going to ask, and with chemotherapy, should it happen first or should surgery happen first?
They look at and they find that patients who have had neoadjuvant treatment followed by breast conserving surgery had better survival compared to patients that had surgery. Because we know about it, so we will put in steps in order for us to handle that side effects for patients.
This episode 4 of the Breast Cancer 101 series offers an overview of medical oncological treatments for breast cancer. Check out the previous episodes on Talcaf Asia's YouTube channel, subscribe and stay tuned for the other breast cancer subtype series.
Now, Dr. Teoh has already covered radiotherapy. Dr. Mastura, let's go to the other treatments, right? Chemotherapy, targeted therapy, and immunotherapy. Can you run us through quickly how these three other treatments play in the role of treating breast cancer?
Okay, so I think I will start with chemotherapy first. So I think everybody knows chemotherapy, everybody fears chemotherapy. So chemotherapy are basically the use of cytotoxic drugs to target and destroy breast cancer cells. So these drugs are usually injected directly into the patient's veins, okay, through the needle, and they're all taken by mouth as pills lah. So chemotherapy can be used to basically increase the chance for cure, by decreasing the risk of the cancer coming back, or what we call recurrence, right? So in those patients with advanced disease, of course, the chemotherapy will alleviate symptoms from the cancer or help these patients live longer by controlling the cancer and also maybe improve the quality of life of the patient. So chemotherapy is still useful, is still being used a lot in addition to surgery, radiotherapy, and hormone. And he has saved many lives, okay? But of course, people are often afraid of chemotherapy because they fear, and then they fear the side effects, right? So what we have to understand is that because it's a cytotoxic drug, chemotherapy kills a proportion of normal actively dividing cells. So often patients ask me, doctor, chemotherapy kills our normal cells, right? The answer is yes, but it's not all. If all, then everybody dies. So it kills just a proportion, just a small portion of the normal active cell. And that's why when we give the chemotherapy, we give it in pulses. We give it one day and then we repeat it after 3 weeks, 4 weeks, 2 weeks, so that allows the normal body cells to recover. But then again, to understand why you get the side effects is because of the action of chemotherapy, where it is not targeted, it is not specific. It kills the normal body cells that are actively dividing in our body, like our skin, our hair, our blood cells, our gut. That's why you get neutropenia, you get thrombocytopenia, you get your platelet counts low. When it affects the gut cells, you get diarrhea, you get constipation, then you get the hair fall, you get the ulcer. So that's the reasons for that. But these side effects nowadays are not severe. Okay, it's not severe. They are mainly mild and they are not permanent. They are often temporary. So very few that are serious or permanent. So talk to your doctor to help decide whether chemotherapy is a good choice for you and how they can basically mitigate the side effects and make it doable for you. So that is actually the chemotherapy.
I was going to ask, and with chemotherapy, should it happen first or should surgery happen first? I mean, this is where I think for us women, lay people, we're very confused.
So basically, if you get a team of doctors, surgeon, oncologists, radiologists, pathologists, sit together and look at the patient's individual case. It's a multidisciplinary team that looks at the case, and they must have all the information available in order for them to make a good decision about what will come first, right? So maybe probably about 50% of patients that in Malaysia, usually they come with, more locally advanced disease, right? When they're diagnosed with cancer, they already have armpit lymph nodes. When when they find the tumor this morning, the tumor is already like 3 cm, 4 cm, it's quite big. So maybe about 40 to 50% of our patients, we may have to give them chemotherapy first. Okay,
I see.
Because of the sheer size or stage of the patient's disease at presentation. But
to shrink the tumor first before you go into surgery.
Correct. Yeah. Among this group of patients where we will give chemotherapy first, they may actually have small tumors, but actually these cancers are the aggressive type. So
Okay.
despite being small, because of the biology of the cancer, like triple negative breast cancer or HER2 positive breast cancer, chemotherapy plus the anti-HER2 or plus immunotherapy are the what we call the recommended treatment first before they go for surgery.
So what
So
happens if someone actually went for surgery first instead
mhm.
of doing the chemotherapy when they should have done the chemotherapy first? Does that affect their survival outcome?
Uh, in some patients, probably it does, because we have studies that showed that neoadjuvant is a large study in I think in Netherlands, where they had, I cannot remember, I think it's probably like 1,000, like 20,000 of patients,
Mm-hmm.
40,000 maybe, that they look at, and they find that patients who have had neoadjuvant treatment followed by breast conserving surgery had better survival compared to
Right.
patients that had surgery upfront followed by their
Chemotherapy.
chemotherapy. And that is the reason behind this, is probably because the patient's the sequence of therapy for the patient has made the subsequent therapy that the patient have to be better. For
I
example, if you
see.
have a locally advanced cancer and you have neoadjuvant treatment first, the likelihood of you removing everything in entirety, the likelihood
Mm-hmm.
of you doing a surgery that is, for a better surgical and cosmetic results. The ability for you to actually minimize the area of radiation,
Okay.
because the tumor
I
is now
see.
smaller, right? And then the
Right.
ability for you to understand about the cancer's behavior when we give chemotherapy. What is the
Mm-hmm.
result? Did the cancer disappear, or did the cancer is stubborn, right?
Okay.
So if let's say
So
the
we can
cancer is
monitor.
stubborn, we can give some more. We can actually, add therapy to what is the standard. So
Mm.
meaning that we tailor the treatment sequence and what this person require according to what is the patient's response to the
So we're
initial therapy.
personalizing treatment, is that
Correct.
right?
So it's personalizing treatment to the individual therapy. So patients who do very well, we de-escalate, means we reduce
Ah,
we reduce the surgery, we reduce the radiotherapy, we reduce the treatment after the surgery is done. But when the patient has a more aggressive cancer behavior, where we give neoadjuvant treatment, we give anti-HER2, maybe we give immunotherapy, then triple negative breast cancer, yet after that, when they have surgery, still a lot of disease still around, right? Then after the surgery, they will have more treatment in order for us to arrest the cancer some more. So like what you're saying just now, is personalizing therapy. So that could be the reason why the survival of the patients who have had that kind of therapy to be better
I
than
see.
the standard that we know lah, like surgery first followed by whatever. So sometimes patients ask me, doctor, my neighbor say, hey, why are you having chemo first? Why not surgery first? I'm still
Mm-hmm.
hearing this now in 2023. so so so
So that's
things
what
have
we have
changed.
tonight, right? So we
Yeah,
can
yeah,
educate everyone and we can learn
yeah.
together.
Correct. Yeah. So things have
Mm.
changed. So I want patients to have faith in how we have, advanced in this manner, where
Medical science.
we doctors talk to each other, like Mei Shi, yeah. So we discuss cases all the time on how we can improve on this particular patient that we are discussing. How best
Great.
can we help the patient? Yeah. Every
Right.
person is unique, so is every cancer. So this is the challenge. So basically, targeted therapy is a drug that is given to a specific character for your cancer. So these are drugs that block the growth and the spread of cancer by interfering with parts of the cells that are
Mm.
involved in cancer growth and progression. Of course, how do we know this? Due to research. So research have shown, for example, HER2 is a molecule that is responsible for cancer growth, progression, and metastasis. Or hormone receptor is responsible for growth of
Right.
hormone receptor positive breast cancer. So by identifying the target in that specific patient, then we can give targeted therapy only to that patient. So patients that do not have the target will be spared from that drug's side effects. So
I see.
the targeted therapy is different from chemotherapy because it is not attacking dividing cells. It's just
Okay.
attacking cancer cells that have that target, right? But there are some cells in our body that also may have HER2, which is like, for example, the heart. That's why we will
Okay.
do our echo,
Yep.
echocardiogram, in order for us to look at how is the heart functioning before we give the
You give the
anti-HER2 drug.
targeted therapy.
Yeah.
Right.
And
So
while we
there
are
are many
giving it,
factors.
yeah, there are many factors. So the spectrum of the targeted therapy is actually broad. So each of the drug class has their own, typical adverse event profile. So that is something that we would, discuss with the patient before we give a targeted treatment. So I put there anti-PIK3CA in hormone receptor positive breast cancer, because like PIK3CA is also a target that we can identify in patients we have hormone receptor positive, HER2 negative, advanced breast cancer. So if let's say the patient has the PIK3CA mutation, which happen in about probably 20-30% of patients, then we can give them the oral targeted pills. Okay, it comes with other side effects, like for example rashes or diarrhea or hyperglycemia, because that target is not the only one that causes cancer growth. It's also like for example controlling the glucose metabolism in the body. So when we give a drug that blocks that that control, then you get some side effects. But because we know about it, so we will put in steps in order for us to handle that side effects for patients.
And with targeted therapy, I mean, I heard that they're quite expensive. I mean, are there like cheaper options available? Are there generics like Panadol and paracetamol?
Yeah, definitely. So there are a lot of a lot of movement, a lot of research being done in creating what we call biosimilars or generic forms of breast cancer therapies. And there are also other like we have generic forms of even hormonotherapy. Okay, some oral pill targeted therapy that are available in the market that are as effective if it's used and manufactured by reputable company that probably have done some also research to look at the safety of the drugs. So I guess any targeted therapy that probably our Ministry of Health has approved is likely to be equivalent.
Right. And I believe they will be then more cost
There will
effective for
be,
the puff.
of course, they will be cheaper. The reason for the originals to be more expensive is because of the research cost that has been
Gone in.
spent in the research and development of these drugs. But once the formula is the drug is that has completed their patency, then you can get the generic or the biosimilar form that is probably as effective.
Can we quickly touch on immunotherapy, Dr. Mas?
Okay, so immunotherapy is the not really the latest kid on the block, because the latest kid on the block is actually the antibody drug conjugate, but that's another day to discuss.
Okay.
But immunotherapy is basically it's a treatment that is targeting one of our own body system that is supposed to be there to guard us from getting cancer. So basically, in our body, we have our immune system. So our immune system is like our police, the policeman of our body, where it is supposed to identify any foreign looking cells. So cancer cells looks foreign to our immune cells. So identify the cells and then attack the cells, or basically kill the cells. So that's what our immune system are supposed to do. But unfortunately, there might be something that the cancer cells produce that makes the immune cell blind to the cancer cell, and therefore the immune cell are not attacking the cancer cells. So how the procedure or the molecule is identifiable within the tumor tissue, again, what you look at under the microscope. So if you could identify those characteristics and we say, okay, okay, so this is the reason why the immune system is not killing the cancer cells. So we could identify that, then we could use what we call immunotherapy, which are drugs that we use to to basically unblind the immune cell that were blinded before, right? So now we unblind them, and now they can go and kill the cancer cells. Yeah. So
Fantastic.
sometimes when we use immunotherapy to kill cancer cells, the immunotherapy probably cannot work alone, you know. So the
Yep.
immunotherapy has to be combined with other therapies such as chemotherapy. So like in patients with triple negative breast cancer, either they are in the early stage or in the advanced stage, we can use immunotherapy in combination with standard chemotherapy in order for us to kill the cancer cells better and, you know, get better results. So that is basically immunotherapy. So immunotherapy now for breast cancer is in, you know, IV form. They are given again injection through the veins. You don't have oral pill at the moment. So yeah, so it also again just like targeted therapy, it also has its own side effects, okay, but they are quite manageable. Any serious side effect is actually pretty uncommon, like probably less than 3%. Like, you know, anything that is life-threatening is probably uncommon. So it's actually a pretty safe treatment to give, and it's also very effective. Like in
Right.
triple negative breast cancer, it, you know, improves survival compared to just chemotherapy alone. And in neoadjuvant breast cancer therapy before surgery, those who have early breast cancer, it also has been proven to be more effective compared to just chemotherapy alone. So that's something that we use as standard practice nowadays in our clinic.
So that's really encouraging to know the combination of immunotherapy together with chemotherapy.
Subscribe to TalkCath Asia's YouTube channel for more health chats episodes or find easy to understand health videos on talkcathasia.com.